And thank you, Torbjörn, for inviting me, and thank you, Smear, for inviting me. So I have a rather modest aim here. I will look at the priority guidelines we made for intensive care during the pandemic and try to answer one specific criticism. Now let's see here. Downwards? That, okay. There we have it. So, as Gustav mentioned, in March 2020, I was responsible for developing the priority guidelines for distributing sort of the last bed in intensive care at the National Board of Health and Welfare. Of course, I was not alone in this work, but I was sort of leading the ethics side together with then experts on intensive care, of course. And as Christian mentioned, we have an ethics platform that has been sort of part of the healthcare law in Sweden since 1997. So that was our starting point, or our frame of reference. And based on that, we decided on the following priorities. So when 2 or more patients have the same severe condition and a similar short-term prognosis for being benefited by intensive care, we should prioritize according to life expectancy based on an assessment of biological age. Or in other terms, prioritize the greatest patient benefit in terms of length gain. So just note a couple of issues here. So we refer to biological age, and why do we do that? Well, because that's a concept actually used in the Swedish legal documents. So in the human dignity principle, it's actually said that we are allowed to use biological age when it relates to patient benefit. So not very clearly defined, but still a concept used there. Another aspect here was that we said, which is interesting in reference to Peter and Kasha's talk, that we said that we shouldn't take quality of life into account. We shouldn't assess quality of life just because we saw some issues or some reports, especially from the US, that people with disability was sort of systematically disadvantaged in the ICU situation without any due sort of cause for prioritizing their quality of life as lower. So those were our statements. So this led to a few different criticism. So the first one was that this is not in line with this legal framework. We were actually breaking the law, some legal scholars have argued. I will not venture into that discussion. We can take that during the question if necessary. The other criticism was that this is at risk of age discrimination. I only touch upon that indirectly. So I will focus on the third criticism that was issued, that this is a turn towards a utility maximizing decision framework for priority setting, and then, as I understand it, implying then that it's a move away from a sort of needs-based framework that we are applying and are, according to law, required to apply. So, these two questions and my conclusions before my argument. So is it a turn towards a utility maximizing framework? Yes. And of course I could end there. It can be, obviously. It can be. It would be supported by and we've heard this from all of you here. Is it a turn away from a needs-based framework? No, I would argue. I would argue, actually, on the contrary, it is required under a reasonable needs-based framework. So, let's start with an example. A suffers from a condition that will kill her in a month. She has preference for living on. The healthcare can offer her treatment X or Y. X give her 3 months of survival, Y give her 5 years of survival. Which treatment should she be offered? And I think most of us could agree that she should be offered Y. And of course, that could be given a utilitarian rationale. It's the greatest patient benefit in this specific situation. But we could also claim, in line with a needs-based approach, to say that, well, A is worse off than she could be. She has a need. And Y would reduce her worse offness or severity more, basically. So when we talk about needs-based approaches, they take an interest, of course, in patients' starting point, and especially to what degree they are worse off than something. And we can discuss what this something is. So you could have the idea that they are worse off than other people in the population, and then we have some kind of egalitarian rationale. Or we could have some idea that they are worse off than some reference level, independent of where other people are in the system, like Derek Parfit has argued. So some kind of prioritarian rationale. And we can have a discussion about that. I will not venture into that today. But let us focus in terms of what could it mean to be worse off in terms of life length? Well, I see two possible interpretations that we are actually using in different contexts. So you can claim that, well, A has been living for a number of years, and that time is shorter than this reference levels or the rest of the population. And of course, the greater discrepancy, the worse the condition. So this would be, in a sense, highly age-dependent. We can call this the Norwegian interpretation. The other interpretation is that, well, A has a very short time to death. And of course, the shorter, the worse the condition. This is less age-dependent, and we can call it the Swedish interpretation. So let's have another example, example 2. B and C both suffer from a condition that will kill them in a month, both have a preference for living on, and are equally bad off. So here is another type of situation. So this is the ICU situation. You only have one treatment. This will bring B an extra 2 years and C an extra 20 years. And if we look at these needs-based approaches, and regardless of in what way we actually assess being worse off, we should, of course, prioritize C to treatment Z, because that would reduce severity more. I mean, there is something bad with being worse off, and if we can reduce the worse offness or the severity, that is better. So we would reduce the gap in life length the most, or we would increase the time to death the most, of course. So on both these interpretations, that would be supported by a needs-based approach. So now I've obviously made an assumption you might not agree with, and that is that more life years for C is better than fewer life years for B, so that you can and should quantify life length gains, and you can make these interpersonal comparisons. And you might instead, of course, side with the British philosopher John Harris, who in the mid-80s wrote a book, but also a famous article where he criticized the QALY. And he argued that there are this equity idea that I think both Torbjörn and perhaps Peter and Kasia touched upon, that equal value of lives. So with then the implication that if we have 5 people competing about this resource, we have A who would gain 2 weeks, B 3 years, C 10 years, D 1 month, E 30 years. We should not, and have no ethically justified reason, choose E before A. You could, of course, agree with that. We should perhaps use a lottery or whatever way we then distribute these scarce resources. But this seems to have an implication for the needs assessment. So if you have no reason to claim that it's worse to die in a week or to gain another week, why should you claim that it's worse to die in a week than in a month, than in a year, than in 10 years? Or if you do the same calculation sort of for the other approach to worse offness. So it seems to imply that everyone with the risk of dying a premature death, wanting to live on, have an equal need of potential treatment, or an equal claim to that treatment. And to me, that means that need as a sort of criteria for distributing scarce resources simply evaporates. I mean, if everyone has the same need, it's sort of not useful as a concept for distribution. And then we would, of course, be left with quality of life criteria, and John Harris says that we shouldn't take that into account either, so yeah, not much left there. So basically what I'm arguing here is that With a needs-based approach to healthcare distribution, worse off is a central concept. And regardless of the exact rationale we use for this, or the exact way to interpret this in terms of life length, we have a reason to reduce the severity or worse offness as much as possible. And hence, in these kind of situation, where we have one last bed, one last ventilator or respirator, and several equally worse off patients, we have reason to prioritize the patients where the severity is reduced the most. Or in other words, our guidelines were in line, and I would say required, by a needs-based approach to actually focus on the patient that where we would achieve the greatest patient's benefit. So maybe this is a way of actually showing what Torbjörn has argued, that we are converging, different theories are actually converging on the same ideas or reasonable idea in this situation. Thank you.
Thank you. So you use the concept biological age and contrast it with chronological age. Chronological age is quite easy to understand. I think that's the ordinary concept. So soon, I think Torbjörn will be 75, yes, given the chronological age. But what is this biological age?
Well, I mean, if you look at the legislation, it's sort of, well, defined, may be a strong word, but it's described as the ability based on the sort of biological status of a person to be benefited by a treatment, and that is, it has sort of an age component. It's sort of statistically related, of course, to the age of the person, but it's not sort of exclusively related to the age of the person. So, of course, a 25-year-old could have underlying diseases that makes him or her less able to benefit, and that is the kind of concept we're using here. Yes.
So to be exact, how do you determine this? I mean, one idea, but that doesn't seem to be the idea that you're talking about, is that you look at what is the average health status of somebody at a certain age. And if you have that health status, you have that biological age.
Yeah, I mean, I think, once again, we might discuss if it's a good concept to use. The reason why we used it in this document was that that's the concept used in the legislation. But of course, it is some kind of, what I think Peter touched on, some kind of assessment of the capacity or prognosis for this patient, where age, but also underlying diseases, other sort of biological statuses.
Can I just be replaced by talking about the expected life, the life expectancy of the person, given an intervention or without an intervention?
Sure, I mean, you could use, and I mean, there are different scales they are using too, like clinical frailty scales, to see whether people are sort of have the capacity to benefit. So I mean, the actual like medical assessment of this is I would say, perhaps rather complicated, but more but in that sense, a theoretical
quite a radical
concept.
shift from chronological age to biological age in priority setting.
Yeah, and of course that's the reason for that is to emphasize it's not just about chronological age. So I mean, in a chronological sense, you should of course sort of make a difference between a 25-year-old and a 75-year-old. But you could of course have a 75-year-old which has such a good biological age and will be benefited more than the 25-year-old. So that was the way of emphasizing that kind of sort of shift.
I think Torbjörn has a follow-up question. So could we get a microphone for Torbjörn?
Sure. Sure. Let's see if I can go the other way. No? Maybe, yeah.
We would like to slide up too.
Yeah, they're working.
Working hard on that. There's too many computers there. There.
Which one?
The first one. I mean, where you describe your idea.
This
one.
Yeah.
I mean, it also a small point relating to this biological age. Is this where we have it?
Yeah.
Yeah. Okay. I mean, I can see the demagogical point here, bringing it in. But isn't it quite superfluous here? I mean, you could just strike it out from this sentence. Life expectancy based on an assessment of in terms of priority, the greatest patient benefit in terms of life length. Again, you can just strike it out, and you have the same content.
Yeah.
And you need not answer Gustav's question.
Exactly. So if you
define
define biological age in terms of expectancy, then this becomes superfluous here. But if you don't, that's why I asked the question.
Yeah, I mean, you could do that, of course. And I mean, I would agree that it does fulfill some kind of perhaps demagogical, or rather a way to emphasize that this is still related to the legislation where they actually talk about biological age. But I mean, it is still a way to emphasize that it's not life expectancy based on this statistical idea that because you're in a certain age, you have statistically a certain expected life length, but rather related to the individual's biological status combined with the age, of course. So that's a way to emphasize something different than the normal, perhaps, life expectancy concept, I would say.
Yeah. Any more questions?
I just wanted to add that it was a terrific talk. I mean, I agree with everything else you said.
Okay, give it to Peter, please. Yeah.
As you were talking about as a benefit, in this slide, it actually says the patients have the same severe condition. But do you have thoughts about where the patients have different conditions, and one of them, let's say, maybe will recover completely and have a normal life, the other may still have serious disabilities and not have a normal life, but possibly will have a longer life expectancy? Are you simply preferring going on life expectancy irrespective of the quality of life?
Yeah, we did that in this case not because it's unimportant and not because the Swedish platform sort of forbids us. I mean, the Swedish platform, I would say, is requires us to do the both, to take into account both life length and quality of life, but rather because in this situation, to assess the sort of long-term quality of life of a person in the ICU would seem to be sort of practically impossible. And we had that dialogue with the intensive care people, and they said, yeah, I mean, we can't do that. And since there were some reports from other contexts that we might do like subjective evaluations based on prejudices about people's sort of future quality of life, we avoided it. But I mean, in principle, of course, that would be an important aspect here. So, and that weighing is, of course, sort of tricky, as you all mentioned. Yeah.
Good. Olle, bring the microphone.
Thank you. Thank you. Very interesting talk. I have a comment on the concept of need.
Yeah.
So this was very popular in the 90s, and there was a very nice article by Tony Collier and Adam Wagstaff from '93, where they define, or they propose, two possible interpretations of the concept of need in the health context. So one would be kind of the individual burden of disease. So a patient with schizophrenia, if you look over the lifetime, might have a higher burden than a patient with chronic depression. And then the second interpretation is the capacity to benefit. So you could probably help the person with depression more, given the technologies of medicines we have, compared to the schizophrenic patient. And they argue that both interpretations are plausible, and it's an ambiguous concept, so they kind of left it. In my reading of your talk, you kind of choose one of them and say that it's the capacity to benefit, that's what's defined need, and you kind of leave the other interpretation. Would you agree?
No, not really, actually. I would. I mean, in my view, the need is a combination of those. So both you have sort of the burden of disease or the severity of the condition, so to speak, but you also, in the needs concept, have the capacity to benefit. So it's a combination of those. Now I focused on the severity side, so to speak, and implied the capacity to benefit, I would say. But I would say both of them. And interestingly enough, if you look at the Swedish legal document, that is also the take in the legal document, saying that need is a combination of the severity, but also you have to take into account the capacity to benefit. So of course you could describe in this. Let's see here. No, wrong. Oh, I'm just pushing the wrong buttons here. So of course you could say in this situation that A is worse off than she could be, and she also has a greater need for Y than X, for example, and in the same way in the other example to say that C has a greater need for the treatment since they have the same severity, but C has a greater capacity to benefit. So that would be my perspective, I think, on this. Yeah.
Are you satisfied with that answer?
Well, not really, because if you change that example, so you had two patients, they would have the same, making them similar, they would have the same needs, the individual burden, but they had different capacity to benefit. And then if you slightly change and say that the one patient has schizophrenia and the other depression, they would have different needs. Yeah. So then you would need to combine both concerns.
Yeah, but I thought I was saying that. Like in this situation, they have the same starting point, so to speak. They have the same, here in this case, they have the same severity of the condition, so the burden of disease is the same. And we might, of course, discuss how do we define that. But since they have different capacity to benefit, I would say that C has a greater need than B in this case. But you could also, of course, say that if they have different starting points and they have different ability to benefit, that would make it even more complicated to compare the needs, of course, because you have two factors that you need to evaluate. But still, that would be my perspective, I think. So.
Good. Any more questions? So I don't see any more questions. So therefore, Lars, thank you very much.
Thank you.